second session. Our second session for the evening will be led by Dr. Srihari R, PharmD Clinical Specialist and Bone Marrow Transplant Coordinator at the Regional Advanced Center for Transplantations, Hemato-Lymphoid Oncology and Marrow Diseases, Believers Church Medical College, Hospital, Kerala. With over 4 years of rich clinical experience, Dr. Srihari has played a role in patient counseling, critical care conditions, and delivering advanced transplant services. He holds a Doctor of Pharmacy from Nazareth College of Pharmacy and has made significant contribution to multidisciplinary care in hematology and oncology settings. Today, he will be speaking on the topic Emerging Trends in Hemato-Oncology Pharmacotherapy. This session will provide valuable insights into evolving treatment strategies, novel therapeutic approaches, and how they are shaping the future of hematology and oncology care. Please join me in giving a warm welcome to Dr. Sri Hari R. Welcome, sir. The stage is all yours. Hello, sir. Can you hear us now? Am I audible? Sir, if you are speaking, you're not audible.
Hello.
Yes, sir. Now you're audible.
Okay. So good evening, everyone. So thank you for the introduction, and I welcome all of you who are present here in the event. So hemato-oncology is the fastest advancing areas of medicine. So and it is changing the way we treat the hematological malignancies like leukemias, lymphomas, and myelomas. And every few months, new therapies are being approved, like CAR T cells, targeted monoclonal antibodies, bispecifics, and all of which are improving the patient care and their survival and quality of life. So today we will look at some of the emerging trends in hemato-oncology pharmacotherapy. So I will start to share my slide right now. Can you see the slide?
No, sir. Yes, sir. Now it is visible.
Yeah. Is it visible?
Yeah.
So coming to the
Yes, sir. Now.
emerging, yeah. So coming to the emerging trends in hemato-oncology pharmacotherapy. So myself, Dr. Srihari, I'm a clinical specialist and BMT coordinator in the Department of Clinical Hematology at Believers Hospital. So what is hemato-oncology? It is a medical specialty focused on the diagnosis, treatment, and prevention of blood cancers such as leukemia, lymphomas, and myelomas. And it integrates the hematology and oncology expertise for complex patient care. And the importance of pharmacotherapy. It plays a central role in inducing remission, prolonged survival, and improving quality of life, it includes chemotherapy, targeted therapy, immunotherapy, and supportive care drugs. The examples include for chemotherapy, it includes bendamustine, clofarabine, fludarabine, triosulfans. And targeted therapies include ibrutinib, acalabrutinib, which are protein tyrosine kinase inhibitors for CLL, mantle cell lymphoma, and Waldenstrom macroglobulinemia, and idealisib and dualisib that are PI3K inhibitors for given for CLL and follicular lymphoma, and venetoclax, which is a BCL2 inhibitor given in AML and CLL, and midostaurin, gilteritinib, which are FLT3 inhibitors for AML with FLT3 mutations, and ivosidenib, which is an IDH inhibitor. Then dasatinib, asciminib, which are BCR-ABL inhibitors given for CML, and obinutuzumab, which is an anti-CD20 monoclonal antibody, which is given in CLL and follicular lymphoma. Then immunotherapies includes blinatumomab, given for relapsed refractory B-cell ALL, which is a bispecific T-cell engages, and inotuzumab ozogamicin, which is given for B-cell ALL, teclistamab, given for the treatment of relapsed refractory multiple myeloma. Then comes the major thing, CAR T-cell therapy, which is given for B-cell ALL, which is treated for B-ALL, DLBCL, mantle cell lymphomas, and myelomas. And checkpoint inhibitors like nivolumab, alemtuzumab, which is given for T-cell ALL. Then supportive care including antibiotics and antifungals for the prophylaxis in neutropenia in hematological patients with malignancies, and GCSF, which is given to improve the total count for neutropenia prevention, and erythropoietin stimulating agents like erythropoietin alpha and darbepoetin alpha, and romiplostim and L-thrombopi for thrombocytopenia, which are thrombopoietin receptor analogs, and iron chelating agents, which used to prevent the transfusion-related iron overloads like deferoxarox and deferoxamine. So in this session, I will be discussing about some of these immunotherapies and targeted therapies. And first, we will come to the CAR T-cell therapy. So what is CAR T-cell therapy? So CAR T-cell therapy is a chimeric antigen receptor T-cell therapy. It is a form of adoptive cell transfer immunotherapy where a patient's T-cells are genetically engineered to express a receptor that targets the specific tumor antigens. It combines the gene therapy and immunotherapy, and it is approved for certain relapsed or refractory hematological malignancies like leukemias, lymphomas, and multiple myelomas. And it includes several steps, which include leukapheresis, that is the collection of patient's T cells, and the genetic modification of the T cells, that is insertion of a CAR gene, that is chimeric antigen receptor gene, using a viral vector to target the specific cancer antigens like CD30, 33, CD19, etc. Then T-cell expansion, that we will proliferate the modified T-cells in the laboratory. And at the simultaneous time, the patient will be receiving a conditioning chemotherapy for the lymphodepletion regimen. And then the CAR T-cell infusion. The modified CAR T-cells are infused into the patients, and then we will monitor the patient. So this is the steps from which the patient's blood is removed to get the T cells, and then the T cells are separated and removed, and which undergo the chimeric antigen receptor therapy, and they are proliferated in the lab. Then the chemotherapy is given to the patient before the CAR T cell therapy, and then the CAR T cells are introduced into the bloodstreams. As it is a modern treatment, it also includes certain adverse effects, which include cytokine release syndrome and immune effector cell associated neurotoxicity syndrome, that is ICANS. And it can also cause prolonged cytopenia and infections, and B-cell aplasia and hypogammaglobulinemia, which will be discussed in the following slide. So the current approved indications for the CAR T-cell therapy include B-cell ALL, large B-cell lymphoma, mantle cell lymphoma, and multiple myelomas. And these are the examples of the CAR T-cell therapy. And coming to the major side effects, cytokine release syndrome. So CRS is a systemic inflammatory response triggered by the factors like infections or immunotherapies. And it is common in potentially severe T-cell engaging therapies like CAR T-cell therapy, CAR T-cells, and blinatumomab. Then the clinical spectrum and symptoms include mild and severe. The mild will be like flu-like signs such as fever, fatigue, headache, rash, arthralgia, myalgia, etc. So in case of severe symptoms, it will be high fever, hypertension progressing to the circulatory shock, vascular leakage, DIC, disseminated intravascular coagulation, multi-organ failures. And lab findings include cytopenias, elevated creatines, and liver enzymes, coagulopathy, and raised CRP. So and also the respiratory issues may escalate, which causes cough, tachypnea, which can cause ARDS, hypoxemia, and sometimes the patient may be requires ventilatory support. And it also causes neurotoxicity and seizures, aphasia, or even encephalopathy. So pathophysiology. Like I said, it is a cascade of inflammatory events initiated by extensive immune cell activation. And the process initiates with the simultaneous activation of multiple immune cell types, including the T cells, B cells, natural killer cells, macrophages, and dendritic cells, which triggers the release of a diverse array of cytokines, with TNF-alpha serving as one of the earliest mediators. And during this initial phase, activated T cells additionally release interferon gamma, interleukins 2 and 8, causing a widespread inflammatory response. And the macrophages also play a central role in the CRS by releasing significant amounts of interleukin 6 and 1, which drive a feedback loop characterized by endothelial activation and vascular leakage, which is the hallmark of cytokine release syndrome. And IL's interleukin 6 is a key mediator contributing the fever, capillary leak syndrome, and hypertension. And the elevated levels of interferon gamma amplify the macrophage activation, leading to the downstream release of TNF alpha, which exacerbates the tissue damage and systemic inflammation. And this excessive cytokine release can result in immune exhaustion and increasing vulnerability to the secondary infections. And in severe cases, the activation of coagulation pathways further exacerbate microvascular injury, contributing to DIC. And the management include, in case of low-grade CRS, we will give supportive care like antipyretics, antihistamine. And in case of CRS, which is grade 3 and 4, we will give anti-interleukin 6R, that is tocilizumab as a first-line agents, and steroids, and other options like anti-IL-6 agents like siltuximab, TNF-alpha blockers like etanercept, and IL-1 inhibitors like anakinra, or immunosuppressants like ATG and refractory situations. So management will be explained in the next upcoming slides. And then immune effector cell-associated neurotoxicity syndrome, which is called as ICANS. It is a reversible neurological syndrome characterized by a range of symptoms from mild confusion to severe cerebral edema. It is caused by immune activation and cytokine-mediated effects on the central nervous system. It typically develops within the day after the CRS, but also can occur independently. Thought to be driven by endothelial activation, blood-brain barrier disruption, and elevated CNS cytokines, especially interleukin 1 and 6. And it is graded according to the ICANS criteria, which evaluate mental status, seizures, motor weakness, and intracranial pressure. The clinical features also include confusion, disorientation, aphasia, tremors, handwriting changes, seizures, somnolence, and or in severe cases, it can lead to coma. And toxicity management, like I said, we will give tocilizumab. ICANS, we will give corticosteroids, seizure prophylaxis. And since the patients are post chemotherapy, they will have low total counts and they are prone to infection. So we will give infection prophylaxis like antibiotics, and we will replace IVIGs. Then close monitoring is in specialized centers. So next upcoming drug is teclistamab, which is also known as Tecvayli. So it is a biphasic antibody indicated for the treatment of adult patients with a relapsed or refractory multiple myeloma who have received at least 3 prior lines of therapy. That is including a proteasome inhibitor like bortezomib and an immunomodulatory agents like lenalidomide, pomalidomide, and an anti-CD38 monoclonal antibodies like daratumumab, and who have demonstrated disease progression on the last therapy. Mechanism of action include, like I told, it is a biphasic antibody. It works by redirecting the T cells to the myeloma cells by expressing the B cell maturation antigen, that is BCMA. It achieves this by binding to CD3 on the T cell, like you can see in the picture, and BCMA on the myeloma cells, and bringing them into close proximity by activating the T cells to kill the myeloma cells. And the dosage and strength include, it is a clear to slightly opalescent, colorless to light yellow preservative-free solution. And it is given as a subcutaneous injection. And it is available in 3 ml glass vial with a blue colored cap, and 1.7 ml glass vial that contains 153 mg of teclistamab. And the dosing schedule. The recommended dose of teclistamab is step-up doses of 0.06 mg per kg and 0.03 mg per kg and 1.5 mg per kg as the first maintenance dose, followed by 1.5 mg per kg weekly once until the disease progression on an unacceptable toxicity. In patients who have achieved and maintained a complete response or better for a minimum of 6 months after the treatment, the dosing frequency may be decreased to 1.5 mg every 2 weeks until the disease progression or unacceptable toxicity. So, like I said, we will give the initial dose for 3 days from like day 1, day 3, and day 5. On the day 1, we will give the 0.06 mg per kg, which is known as the step-up dose. And on the third day, we will give it as 0.3 mg per kg, that is the step-up dose too. The teclistamab can also cause cytokine release syndrome and ICANS. So we are giving this step-up dose to monitor the CRS and ICANS in the patients. If they are not having any symptoms, we will go into the final dose of teclistamab of 1.5 mg per kg. So after the initial maintained dose, we will be changing them to ongoing weekly dose, like for day 1, weekly ones, 1, 8, 15, and 22 of teclistamab. That is 1.5 mg per kg as sub. And after that, when the patient achieves a complete response for a minimum of 6 months, we will start an weekly dose. So the patient, like I said earlier, patient should be monitored for cytokine release syndrome and immune effector cell-associated neurotoxicity syndrome ICANS for 48 hours after the step-up doses on days 1, 3, and 5. And the patient should remain within the proximity of healthcare facility or be treated as an inpatient during this period. And the minimum dose interval between these doses should be 2 days. And a minimum of 2 days should be maintained between the step-up dose 1 and 2, and the step-up dose 2 and the first maintenance dose. And a minimum of 5 days should be maintained between the weekly maintenance. And the recommendation for restarting the teclistamab after a dose delay is as mentioned like below. For the step-up dose 1, if it is delayed for more than 7 days, we have to restart the step-up dose 0.06 mg per kg. And for the step-up dose 2, 0.3 mg per kg, if it is delayed for 8 to 28 days, we need to repeat the step-up dose of 0.3 and to continue step-up schedule. And if it is more than 28 days, we have to go from the initial step-up dose 1. And for any maintenance doses, duration, if it is between 8 to 28 days, we have to continue the maintenance dose at the previous schedule. And if it is greater than 28 days, we have to start from the step-up dose 1. And recommended treatment medications will include dexamethasone, chlorpheniramine, paracetamol. And we should continue the pre-medication for subsequent doses of teclistamab in patients who require repeat doses of the step-up schedule due to dose delays, experience cytokine release syndrome with the previous doses. And the administration. It is injected into the subcutaneous tissues of the abdomen, which is mostly preferred, or alternatively, it can be injected into the subcutaneous tissues at other sites, like thigh. Each injection volume should not exceed 2 ml, and the doses greater than 2 ml should be divided equally between multiple surgeons. And if multiple injections are required, the injection should be administered at least 2 centimeter apart. And do not press or rub the site of injection, and do not inject into the areas where the skin is red, bruised, tender, hard, or not intact. And coming to the adverse reactions, these are the following can caused by teclistamab. That hematological include neutropenia, anemia, thrombocytopenia, lymphopenia, and non-hematological include mainly cytokine release syndrome and other diarrhea, fatigue, pyrexia, and it can also cause constipation, cough, pneumonias, etc. And specific drug-related side effects and its management. Coming to the cytokine release syndrome, like I said earlier, it includes a life-threatening or fatal reactions which can occur after that for patients after receiving teclistamab. And the clinical signs symptoms include fever, hypoxia, hypotension, tachycardia, headache, and elevated LFT. And if CRS is suspected, treatment should be withheld and the following investigation should be done. That is FBC, UNDs, and LFTs, bone profile like calcium and all, CRP, ferritin coagulation screening, chest X-ray, and ECG. And based on certain grades, it is managed accordingly. So coming to the grade 1, if the symptoms like temperature, if the patient is having temperature greater than 38 degrees Celsius and no hypoxia or hypertension, we will manage it as we should monitor the vitals every 4 hours, and it should be treated as neutropenic sepsis protocol. And we should consider early tocilizumab dose. Like the tocilizumab is given at 8 mg per kg, which includes a maximum of 800 mg over 1 hour. And coming to the grade 2, if the patient is having temperature greater than 38 degrees Celsius with hypertension or responsive to fluids, we will manage like the grade 1 and also consider the IV methylprednisolone 1 mg per kg BD. And we should also start them on oxygen and fluids. And coming to the grade 3, if the patient is having temperature with hypertension requiring vasopressor or hypoxia requiring 6 liter, more than 6 liter of O2, it is also treated as neutropenic sepsis, and we will administer tocilizumab 8 mg per kg every Q8H, and we will continue methylprednisolone 1 mg per kg. And if refractory, if the patient is still having these symptoms, we will consider IV methylprednisolone 1 gram or alternative immunosuppressive agents like anakinra. For recurrent grade 3 CRS, permanently we should discontinue the teclistamab. And for grade 4, which the patient is having temperature 38, greater than 38 with hypertension requiring multiple vasopressors or hypoxia requiring BiPAP or ventilation, we should uh, shift them to ICU and treat as the same. And we should permanently discontinue the teclistamab and should monitor the patients. And in case of ICANS, so we should monitor for every day for the ICANS with the ICE assessment tool. So we should check ICE score twice a daily while an inpatient and twice a day for 48 hours as an outpatient during the step-up dose. And if the grade is if the grade 2 or higher ICANS experience, patient should be monitored as an inpatient for 48 hours following the next dose. And if ICANS is suspected, a neurological examination should be performed in addition to the following investigations like ECG, 3 times a day ICE assessment, MRI brain or CT brain, and a lumbar puncture. And the management of ICANS should be based on the table with the ICE assessment tool. And we will ask the patients every day these kind of questions, and we will make a score from that. And the management will be based on the ICE scoring like this. If the ICE score is ICE score and symptoms score is 10, there will be no ICANS. And if it is between 7 to 9, with the, it is mentioned as grade 1 if the patient awakes spontaneously. And it is mentioned as grade 2 if the score is 3 to 6, if patient awakes to voice. And between scores 3 to 3, the ICE score should be 3 times a day, and regular neurological observation should be done, and to consider tocilizumab with concurrent CRS. And if the further monitoring, if the ICE score becomes 7 to 9, and the patient is having persistent symptom, we should consider IV dexamethasone 10 mg QD until resolution, then taper. And we should also consider seizure prophylaxis. And if the score is between 3 to 6, we should continue the IV dexamethasone and administer anti-epileptics and consider EEG and imaging. And for grade 3 and 4, grade 3 will be between score 0 to 2, and the patient awakes to tactile stimuli like seizures resolve rapidly on focal cerebral edema on imaging. And in case of grade 4, it is score 4, and the patient will be unarousable, prolonged, or frequent seizures. Patient will be having frequent seizures or motor weakness, diffuse cerebral edema on imaging. The patient should be transferred to ICU, and we should monitor the ICE for 3 times and perform neuroimaging and lumbar puncture, and we should consider tocilizumab. And after that, the patient is still having 0 to 2 and arousable, we should administer IV dexamethasone. And if refractory, if the patient is still having symptoms, we should consider methylprednisolone 1 gram daily for 3 days. We should taper when the symptoms improve. And the patient is having score of 3 and unarousable, we should administer IV methylprednisolone 1 gram per daily for 3 days and taper when the symptoms improve. And for refractory patients, consider alternative therapies like anakinra. And coming to the next drug, which is obinutuzumab. So obinutuzumab is a humanized type 2 anti-CD20 monoclonal antibody. It is engineered to target CD20 positive B cells in hematological malignancies. It is the first glyco-engineered antibody of its kind, designed to enhance antibody-dependent cellular toxicity, that is, and direct cell death, distinguishing it from type 1 antibodies like rituximab. So the mechanism of action, like I said, it is a monoclonal antibody that target CD20 antigen expressed on the surface of pre-B and mature B lymphocytes. And upon binding the CD20, obinutuzumab mediates a B cell lysis through 3 steps. That is direct cell death. That is, obinutuzumab directly triggers the programmed cell death within the B cells upon binding to the CD20. And antibody-dependent cellular toxicity. That is, obinutuzumab activates the immune effector cells like natural killer cells and macrophages to target and destroy the B cells. And complement-dependent cytotoxicity. Obinutuzumab can also activate the complement cascade, a part of the immune system that can directly damage the membranes and lead to cell death. And the indications include chronic lymphocytic leukemia and follicular lymphoma. And dosage and administration. It should be diluted and administered as an intravenous infusion, and we should not give it as IV push or bolus. And the recommended doses is for 6 cycles, that is every 28 days. And for the initial part, we will give it for 2 days. And first day it will be given as 100 mg, and next day it will be given 900 mg. And from the next day onwards, we will give it as 100 mg. So to complete the cycle 1, and from the cycle 2 to 6, we will give the 100 mg itself. And it is available as a 100 mg for 40 ml single-use vial. And the pre-medications include for cycle 1, day 1 and 2, all patients requires intravenous glucocorticoid, that is 20 mg dexamethasone or 8 mg methylprednisolone, 650 to 100 mg of acetaminophen, and antihistamines like diphenhydramine. It should be given, the glucocorticoid should be given 1 hour prior to the gastric infusion, and at least the antihistamines and acetaminophen should be given at least 30 minutes before the infusion. And for cycle 1, day 8 and 15, and cycle 2 to 6, all patients should be given the same. And if the patient was having a infusion rate reaction in the previous infusion, we should give antihistamine at least 30 minutes. And if the patient is having grade 3 infusion related reactions and with the lymphocyte counts greater than 25,000 prior to the next treatment, we should give intravenous glucocorticoid like dexamethasone 20 mg, which should be given 1 hour prior. And dosage and administration. The dosage include cycle 1 will be given as 100 mg on day 1, which is infused as 25 mg per hour over 4 hours. And we should not increase the infusion rate. On day 2, it is 900 mg is given at a rate of 50 mg per hour. And the rate of the infusion can be accelerated in the increments of 50 mg per hour every 30 minutes to a maximum rate of 400 mg per hour. And we should look for any hypersensitivity or infusion related reactions. And for the cycle 1, day 8 and 15, we will given it as 100 mg. And from cycle 2 to 6 onwards, we will given the 100 mg as at the rate of 100 mg per hour, and we can increase it by 100 mg per hour increments every 30 minutes to a maximum of 400 mg per hour. And the side effects, very common side effects include severe and life-threatening infusion-related reactions like anaphylactic shock, then shivering, hives or itchy rashes. And the common side effects include neutropenia and tumor lysis syndrome if the disease burden is high. And the gastrointestinal perforation can also occur due to this drug. And uncommon side effects include infection, thrombocytopenia, and heart disease, progressive multifocal leukoencephalopathy, and DAs. And rare conditions can cause hepatitis B infections. And the storage. It is stored as single-use vials containing preservative-free solution, and it is stable at 2 to 8 degrees Celsius. And coming to the next drug, it is alemtuzumab. It is available as 2 drugs, that is Lemtrada, 2 brand names, that is Lemtrada, which is a 12 mg of 1.2 ml drug, and then next one will be Campar, which is 30 mg per 3 ml. So the Lemtrada is indicated for the treatment of patients with a relapsing form of multiple sclerosis, and it is generally to be reserved for patients who had had an inadequate response or 2 or more drugs indicated for the treatment of multiple sclerosis. And the recommended dose of Lemtrada is 12 mg per day administered by an intravenous infusion for 2 treatment courses. And the first treatment course is 12 mg per day on day 5 consecutive days, that is 60 mg of total dose. And second treatment course include 12 mg per day on 3 consecutive days, that is 36 mg of total dose, which is administered 12 months after the first treatment course. And coming to the camber, which I will be more explaining. So it is a CD52 directed cytolytic antibody indicated as a single agent for the treatment of B-cell chronic lymphocytic leukemia. And recommended dosing regimen include: we should gradually escalate the maximum recommended single dose of 30 mg. And the escalation is required at an initiation of dosing or if dosing is held greater than or 7 days during treatment. And escalation to 30 mg ordinarily can be accomplished in 3 to 7 days. And the total duration of the therapy, including dose escalation, is 12 weeks. So, coming to Camber. Camber is a recombinant DNA-derived humanized monoclonal antibody. It is directed against the 21 to 28 kD cell surface glycoprotein CD52. And Camber is an IgG1 kappa antibody with human variable framework and constant regions and complementarily determining regions from a murine monoclonal antibody. And it is produced in mammalian cell suspension culture in a medium containing neomycin. And the neomycin is not detectable in the final product. And it is a sterile, colorless isotonic solution with a pH of 6.8 to 7.4 for injection. And each single-use vial of Camber contains 30 mg of alemtuzumab in 3 ml. And it does not contain any preservatives. And coming to the mechanism of action, the Camber bind to CD52, an antigen present on the surface of B and T lymphocytes, and a majority of monocytes, macrophages, natural killer cells, and a subpopulation of granulocytes, and a proportion of bone marrow cells, including some CD34 cells, express variable levels of CD52. The proposed mechanism of action is antibody-dependent cellular-mediated lysis following cell surface binding of Camber to the leukemic cells. And this is the mechanism of action of Camber. It includes CD52 expression on the lymphocytes and the complement-dependent cytotoxicity, then antibody-dependent cellular cytotoxicity. Then the dosage and administration. It is given as an IV infusion over 3 hours. It is not given as an intravenous push or bolus. And the recommended dosing regimen, as I said earlier, should be escalated to maximum recommended single dose of 30 mg. And the escalation strategy include administer 3 mg daily until the infusion reactions are less than grade 2. Then administer 10 mg daily until the infusion reactions are grade 2. Then we can administer 30 mg per day for 3 times per week on alternate days. And the total duration of therapy include dose escalation is 12 weeks. And the single doses of greater than 30 mg or cumulative doses greater than 90 mg per week increase the incidence of pancytopenia. And recommended concomitant medication, that is pre-medications, include we should pre-medicate with diphenhydramine and acetaminophen 30 minutes prior to the first infusion and each dose escalation. And institute appropriate medical management like steroids, epinephrine, meperidine, or for infusion reactions as needed. And advice reactions, and also we should administer trimethoprim sulfamethoxazole DS twice daily, 3 times per week for PCP prophylaxis. We should also administer famciclovir for herpes prophylaxis. And we have to continue PCP and herpes viral prophylaxis for a minimum of 2 months even after the completion of Camber or until the CD44 plus count is greater than 200 cells per microliter. And the dose modification. In case of serious infections or serious adverse reactions, we should withhold the Camber until the resolution of the symptoms and discontinue the Camber for autoimmune anemia or autoimmune thrombocytopenia. And there is no low dosage modification at present recommended for any lymphopenia. And the dose modification for neutropenia and thrombocytopenia include if the ANC is less than 250 per microliter or platelet less than 25,000. And for the first occurrence, we should withhold Camber therapy and resume Camber at 30 mg when the ANC is greater than 500 per microliter and platelets greater than 50,000. And for the second occurrence, then we should withhold the Cambat therapy and resume Cambat at 10 mg when the ANC greater than 500 or platelet greater than 50,000. And in case of third occurrence, we should discontinue the Cambat therapy. And greater than 50% decrease from the baseline in patients initiating the therapy with baseline ANC less than 250 or a baseline platelet count of less than 25,000. And for the first occurrence, we should withhold Cambat therapy and resume the Cambat at 30 mg upon return to baseline values. For second occurrence, we should withhold and resume it at 10 mg. And for third occurrence, we have to discontinue it. And laboratory monitoring. We should obtain complete blood counts at weekly intervals during Cambat therapy and more frequently if worsening anemia, neutropenia, or thrombocytopenia occurs. Assess the CD4 plus counts after treatment until recovery to 200 cells per microliter. And preparation and administration. The parental drug product should be inspected visually for any particulate matter and discoloration prior to administer. If particulate matter is present or the solution is discolored, the vial should not be used. And we should not shake the vial. And to prepare the 3 mg dose, we should withdraw 0.1 ml into a 1 ml syringe. Then for 10 mg, we should withdraw 0.33 ml. And to prepare 30 mg dose, we should withdraw the 1 ml, either a 1 ml or 3 ml syringe calibrated in 0.1 ml increments. And we should inject the syringe contents into a 100 ml sterile 0.9% sodium chloride or 5% dextrose in water. And the vial contains no preservative as is intended for single use only. And we should discard the vial, including any unused portion after withdrawal of any dose. And it should be used within 8 hours of dilution. And it should be stored and the diluted Cambat should be stored at a room temperature of 15 to 30 degree or refrigerated at 2 to 8 degrees Celsius. And it has to be protected from light. And adverse reactions include cytopenias. It includes severe, including fatal autoimmune anemia and thrombocytopenia. Prolonged myelosuppression has also been reported. And in addition, the hemolytic anemia, pure red cell aplasia, bone marrow aplasia, and hypoplasia have been reported after treatment with Cambat at the recommended dose. And single doses of Cambat greater than 30 mg or cumulative doses greater than 90 mg per week increase the incidence of pancytopenia. And withhold Cambat, we should withhold the Cambat for severe cytopenias except the lymphopenia. And we should discontinue for autoimmune cytopenia or recurrent or persistent severe cytopenias. And infusion reactions. Adverse reactions occurring during or shortly after Cambat infusion include pyrexia, chills, rigors, nausea, hypertension, urticaria, dyspnea, rash, emesis, and bronchospasm. And infusion reaction has been identified in post-marketing reports, include syncope, pulmonary infiltrates, acute respiratory distress syndrome, that is ARDS, respiratory arrest, cardiac arrhythmias, myocardial infarction, acute cardiac insufficiency, cardiac arrest, angioedema, and anaphylactoid shock. So we have to monitor the patients for these. We should initiate the Cambat according to the recommended dose escalations. Pre-medicate the patients with antihistamine and acetaminophen prior to dose, and institute medical management like glucocorticoid, epinephrine, meperidine for infusion reaction sustain. And if the therapy is interrupted for 7 or more days, we should reinstitute Cambat with a gradual dose escalation. And immunosuppression or infections. The Cambat treatment results in severe and prolonged lymphopenia with a concomitant increased incidence of opportunistic infection. And we should start, like I said earlier, PCP, like pneumocystitis jirovecii and herpes viral prophylaxis during the Cambat therapy for a minimum of 2 months. And the prophylaxis does not eliminate this infection. We should routinely monitor the patients for CMV infection during Cambat treatment for at least 2 months following completion. And we should withhold Cambat for any severe infections during antiviral treatment for CMV infection or confirmed CMV viral anemia defined as PCR positive CMV. And we should initiate therapeutic ganciclovir for CMV infection or confirmed CMV viral. And we should administer only irradiated products to avoid transfusion-associated graft versus host reaction disease unless emergency circumstances dictate the immediate transfusion. And in patients receiving Cambat as initial therapy, the recovery of CD4 plus counts to greater than or equal to 200 cells occur by 6 months post-treatment. However, the 2 months post-treatment, the median was around 183 cells. In the previously treated patient receiving Cambat, the median time to recovery of 4 plus counts to 2, greater than 200 was 2 months. However, full recovery of CD4 plus and CD8 plus count may take more than 12 months. And the most common adverse reactions include infusion reactions, like I said earlier, like pyrexia, chills, hypertension, urticaria, tachycardia, dyspnea, and cytopenias like pancytopenia, CMV viremia, CMV infections, and other infections. Then gastrointestinal symptoms like nausea, emesis, abdominal pain, and neurological symptoms like insomnia and anxiety. And in case of overdosage, across all clinical experience, the reported maximum single dose received was 90 mg. So, bone marrow aplasia, infections or severe infusions reaction occurred in patient who received a dose higher than that recommended. Then one patient received an 80 mg dose by IV infusion, experienced acute bronchospasm, cough and dyspnea followed by anuria and death. And another patient, according to the study, received 2 doses of 90 mg doses by IV infusion 1 day apart during the second week of treatment, experienced rapid onset of bone marrow aplasia. And there is no non-specific antidote for Cambath overdosage. And treatment consists of drug discontinuation and supportive therapy. And the storage and handling. And the Cambath is supplied in a single-use clear glass vials containing 30 mg of alemtuzumab in 1 ml solution. And each carton contains 3 Cambath vials. That is one or 1 Cambath vial. And we should store it in under 2 to 8 degrees Celsius. We should not freeze it. And if it accidentally frozen, we have to thaw it at 2.2 to 8 degrees Celsius before administration. And it should be protected from sunlight. So these are the references. Thank you.
Thank you so much, sir. Guys, we are now open to questions, so feel free to write your questions in the chat box. So, Anirudh asks, which among immunotherapy and targeted therapy have low hematologist or non-hematological toxicity?
So most of these drugs have hematological toxicities, and we have to manage them accordingly. Usually, like I said, in these all drugs I have discussed have the hematological toxicities like neutropenia, which can cause thrombocytopenia and anemia. And we have to manage with the supporting medications like that, like I said earlier, thrombopoietin receptor analogs like L-thrombopipe, romiplostim, and GCS granulocyte colony stimulating factor for improving the neutropenia, and we have to transfuse them.
So the next question is, which among immunotherapy and targeted therapy has no or minimal CRS toxicity based on CTCAE criteria?
So and the CRS toxicity mostly cause on the initial stage. In case of teclistamab, if the patient is having the CRS only in the initial stages of the treatment, and after that, if it is more than grade 3 or 4, we have to discontinue the therapy. Or other cases, if we can manage them accordingly, we have to give like the agents like immunomodulators like tocilizumab before the infusion, and we should continue them like Q8H.
Thank you, sir. Guys, do we have any more questions? I think that's all the questions, sir. Thank you so much, sir, for this insightful session. We really appreciate you for sharing these insights with us. Let's have a huge round of applause for the sir.
Okay, thank you, RX doctors, for giving me an opportunity to present. Thank you so much.
Thank you so much, sir. And a heartfelt thanks to both of our distinguished speakers today, Dr.